So.
Um, Good evening to all Indian neurosurgeons and morning for all the surgeons in US. This is the second, I welcome you all for the second webinar on controversies in vascular neurosurgery. We will be having four of these. The next one will be on 11th of November and the fourth one will be on 9th December. The next one is on controversies in managing on vascular tumors. Today the topic is on controversies in AVM. All of us know that the risk of yearly hemorrhage in unruptured one is almost 2 to 4%, and the mortality is quite high, is almost 13% in first hemorrhage, 20% in second, and 25% in third hemorrhage. So one cannot just observe or have a conservative treatment in AVMs. And the smaller the AVM, the higher the chance of rebleeding. The smaller AVM, the nidus is less than 3 centimeter, they have an 82% increased risk of rebleeding. So even if you have a small AVM, that has to be treated rather than the larger ones, which probably are innocuous. Now, today we are concentrating on AVMs in the eloquent area, like this lady who had come with intractable seizures with AVM in the motor cortex, and this another young girl had come with just headache and one episode of bleed and with a AVM in the motor cortex. And this one we attempted surgery, but during surgery everywhere it was stimulations were positive, so we just had to abandon surgery, and we suggested radiosurgery. We do not know whether that is the right way to go or not. That's what today we will discuss, whether radiosurgery or embolization or microsurgery is the way to go. And this was another lesion which was in the occipital cortex with the visual perimetry was normal. So what is the best option, whether to do radiosurgery, embolization, or microsurgery? As we know that observation is not an option in small AVMs. So today we have Professor Atul Goyal, head of the department of KEM Hospital, Bombay, to speak on issues in surgery of cerebral AVMs in eloquent area. We have Professor Manmohan Singh, the professor of neurosurgery at All India Institute of Medical Science, Delhi, to speak on controversies on radiosurgery of eloquent AVM. We have Professor Pascal Jabor from, he's a dual surgeon, both he does endovascular as well as microsurgery from Thomas Jefferson University Hospital, US, and he'll be speaking on multimodality management of AVM. And we have Dr. Srinivasan Paramasivan from Apollo, head of the Department of Endovascular Surgery at Apollo Hospital, Chennai, and he'll be speaking on endovascular treatment of AVM in eloquent area. We have three panelists: Professor R.C. Mishra, the head of the department of Rainbow Hospital at Agra. He was ex-president of NSI, as well as he was involved in the NSI CNS cooperation earlier. And we have Professor Daljit Singh, head of the department of GB Pant Hospital. He also is a dual surgeon. He does a lot of endovascular procedures as well as microsurgery. And we have Professor Brian Jankovic. He's director of cerebrovascular surgery at the Cooper Neurosurgical Institute, and they will be the panelists, and they will give the final opinion with case presentations in the discussion. And me and Professor Clemens will be moderating today. And before we start, I will request Professor Clemens to introduce Professor Goel and invite him to give his lecture. Thank you.
Yeah, thank you very much. And, I really want to, thank all of our friends from the Neurological Society of India for again coming together here and proceeding with the series. And it is my distinct honor and pleasure to introduce Professor Atul Goel. And he's going to talk us through issues in surgery of cerebral Avms in general, and really give us his long-term perspective on these issues over time. So without further ado, thank you, Professor, already, and let's hear what you have to say. And you're still muted.
Okay, now you can hear me probably, right?
Yes.
Okay. So I am going to take you to my world of arteriovenous malformation. You see, there is a question mark about arteriovenous malformation treatment. This question mark was not there 30 years ago or 25 years ago when there was no radiosurgery, when there was no interventional radiology, and the things were very happy. Yasser Gill, Kobayashi, Sano, and several Sugita and several neurosurgeons were doing AVM surgery, and there was no confusion. I will say with the introduction of radiosurgery and with the introduction of interventional, the things have changed, but whether they have really changed and whether they have to be changed further, I'm not sure. As far as I am concerned, the things have not changed. This is my perspective. My feeling is for AVM, embolization is still a very controversial issue, and radiosurgery is also a controversial issue. There are two forms of treatment. One is there is no treatment. You do not touch the AVM. You do not do anything. Just leave him. And second thing is a curative treatment, and that is surgery. Surgery is the only proven method of treatment, but it is dramatically dangerous in some cases. That is the reason. That is one single reason why the other forms of treatment will survive. Not only survive, they will thrive because surgery is difficult and surgery can be impossible. So if this kind of patient with a severe headache, you see a young girl with headache and has a large AVM, now what you want to do, whether you want to do multiple embolization or whatever you want to do, or whether you want to take the difficult task of removing this AVM. The question is whether you can do it. Because if you can do it, this young girl can be cured and this girl can have a nice smile in the immediate post-operative period and the matter is finished and she is cured for life. These are benign lesions. The issue is whether it is possible in your hands to do it. Here is another very, very elegant young man, no otherwise handsome, running around here and there, comes with complaints of few episodes of convulsions. Now, whether you want to take this, you see these things are benign things. You cannot create a complication here. Who had one or two convulsions, that may be devastation. On the other hand, there is a possibility that if you have the skill, if you have the confidence, if you know how to do it, if you can resect it, you give new life. This is another patient. You see, I am not sure today I will do it or not. This I had done several years ago in the speech area in a dominant hemisphere. Convulsion was the issue. You see, you remove the AVM, you never know convulsions will go or not. But the AVM can go if you remove, but also the patient can have a very dangerous deficit, speech deficit, hemiplegia, this and that, which is not acceptable at all. You see, if you are not able to do, it is better to raise your hand and say, I am not able to do, I am sorry, I am not capable of doing. But over the period of time, AVM surgery has progressed, investigations have progressed. You see, this is the AVM in quite a complex situation. You see the beautiful 3D angiography, which is possible. You see the MR angiography, which is possible, MR imaging showing the intraventricular. Imagine if this was outside the ventricle, you cannot do it. If it is inside the ventricle, you can attempt to do it because inside the ventricle, the things are much easier. And you see the DTI imaging, the whole thing is inside the confines of the ventricle. So it is a possibility to operate this lesion. So we had tried for a long time, we were using these kinds of cells. These are 3D models. These were initial generation, but then we improved on these models. And these three models, I think we were the first one in the world to, I'm not sure, I will ask the other people on the panel whether 3D models were in use in US, but we published it for the first time for sure. 3D models, and these models are quite useful. You see, this is the angiography, you know where is the AVM and things like that. But if you have this kind of model in your hand, if you can hold it in your hand, you know exactly where is the center of activity. And then you can circumferentially plan how to do, what to do and what not to do, and do it in a beautiful manner. This is another 3D model, and you see this patient was not considered to be fit for surgery. So AVM surgery is a difficult, dangerous issue on many situations, but on many situations, it is quite straightforward and simple. We should not say, I cannot do AVM. We should not get the feel that AVM word is a dangerous word, because many of these AVMs can be quite easy. So this is my personal classification. You see, personal. This classification is not fit for anybody else. Whatever is easy for me may be absolutely easy for others, or whatever is not safe for me may be difficult for you. So this is my classification. Over the years, I have improved on this classification. Earlier, which were not safe, are now little better or little better. So this is my classification. Whenever an AVM comes, I like to introduce this classification and then take a decision whether I can operate, whether I will not devastate, whether I will not create a complication. And this decision is on a very tight rope. You cannot take a decision which is wrong. If you take the decision, I can operate, and during operation you cannot do, that will be a very dangerous situation. So this was one AVM of this young man who was a farmer from a village. Only symptom of headache. Long time I was saying, no need for treatment, don't go, run away, this and that. But this fellow kept on jumping on me with headache. But that jumping doesn't mean anything. You don't jump because he's jumping. You have to jump in this case only when you think you can bring him out jumping. If you bring him out hemiplegic or this kind of situation, that will be not acceptable. He will not accept it after the operation if he is in a difficult situation. So this patient we operated at that time after considering the easy situation. Every AVM has some good points, every AVM has some bad points. So you have to identify the flow of the nidus, if you can identify the site of major artery which you can go by intrahemispheric fissure, which artery is bleeding, and you have to plan the operation beforehand. I will deal with this artery first, I will deal with that artery second, I will deal with this artery third, and I will deal with this artery 100, and then I will do this artery 200, and then I will deal with this vein. So we have to plan this operation absolutely, and you have to study hard on this. This is another case with, by mistake, I told this guy, he came with only one headache, his wife actually, and I told you are having a worms in your head. By mistake, I told him. He said, why don't you give him some deworming tablet or something? I said, my dear friend, this is not that kind of worms. These are dangerous worms, and these are, difficult worms. So I ultimately, because of the severity of the headache and the absolute severity and some good points in the AVM surgical points, I removed this AVM in a very fantastic manner. Here is the little bit video, but I don't think I will show this one, maybe some other one. You see the whole brain. It is not like a meningioma. You have to plan somebody told me whether you remove partially, whether you remove subtotally. No subtotal and partial and all these foolish things. You have to remove it completely. Can you do it 2 stage? Absolutely not. You have to do 1 stage. You have to plan and finish. You cannot say, I will half dress. You have to dress fully and beautifully. This is another patient. You see, I'm showing you some trophies. I'm not saying these are, no, I have never had a complication or something like that. These are some trophies which give you pleasure and define your surgical status. You see, this is one AVM. This is the lady came with severe giddiness. She was not only giddy, she was absolutely making everybody around her giddy. So this was giddy situation for me also. And was refusing surgery for a long time, but ultimately I decided, because there was some good points, not because she was giddy. Good points were, there is one large anterior cerebral artery. That is good point. I can come into hemispheric, get this artery. Then there was a large PCA. I can come into hemispheric, get to the PCA. These are good points. You see, this is very high flow AVM. You see the internal jugular vein, superior vena cava, like, they have devastated the whole scenario. It will bleed. It will bleed furiously. During the operation, it will bleed from here, it will bleed from there, it will bleed from everywhere, wherever you see blood. So are you ready to do this? Are you saying, okay, go embolize and go radiation? That is the easier option. But if you want to cure this, if you want to give a wonderful smile and on this face and on your face, try to do. And I am saying these are the more difficult ones, but there are several cases which are not difficult. This is another, you see, dangerous speech area, dangerous motor area. I'm not sure today I will do it or not, but this was my historical, beautiful cases I'm showing you. Issue whether convulsions have stopped or not, I'm not sure, but this was completely and beautifully resected. Another bag of worms, you see, huge. And another marginal symptoms of some convulsion here, some convulsion there. And but the issue was not convulsion. You can give anticonvulsant drug, but whether you can try to attempt. So find out the issues which are good for surgery, find out the loose areas, of whether you can get to the feeder, whether you can get to the feeder easily, whether it will bleed. You should know how, whether there are aneurysms inside, how much is the flow, how much, and when you start, you have to be king, and you have to be a solid rock, and you have to control the whole theater, and you have to control bleeding, most important. You theater control and bleeding is not, you will be a ridicule. So you have to fantastically control. It will bleed from here, it will bleed from here, it will bleed from here. Sometimes it will bleed from 3 or 4 places. You will see, think that now it is gone. But the situation is you have to win that situation, and you have to conquer that situation, and ultimately you have to conquer the whole AVM. And you cannot say, I have removed half the AVM, I have removed big feeders and all these stupid things will not. Here, fantastic. And it is a microsurgical operation. This operation also had done long time ago. You see the region in the vein of Galen. I will say, you have to find out the weak points. Weak points is the PCA feeder. PCA feeder is the one which you can get interhemispheric PCA feeder early in the business, and then you can get the anterior cerebral artery feeders, and then you can circumferentially come around the AVM. See, this one is also dangerous looking AVM, but there is a PCA which is large and which is feeding a large part of the AVM. The trick of the trade is to go interhemispheric, get to the PCA earlier in the surgery, and that trick is very dangerous and difficult trick. But if you know that trick, this is also one AVM, which is quite a looking AVM going into the velum interpositum. But you see, the beauty is there is one large anterior cerebral artery and one that is a large PCA artery. So both these arteries can be held if you come from the interhemispheric fissure, and then you can circumferentially dissect, and be strong and conquer this field. And once you conquer, you have conquered the world. And that trophy you can show like this in various meetings. Basically, you see, this is another AVM. This parieto-occipital is a little bit good area for surgery. But this AVM is the one of the most vascular AVM I had done. Huge. You see this coming from this side, coming from NCA, coming from ACA, coming from contralateral ACA. This multiple territory feeders are more dangerous kind of AVMs, but then you have to be, but this is more less eloquent area in general, but you can do it. And if you have the will, you can have the way. Only thing is that will should not be, make the patient sign his will or something like that. You have to have the will which is strong and which is personal. This is Sylvian Fisher AVM. This looks quite dangerous. But if it is dangerous because of the multiple vessels, but they are not very dangerous. Sylvian Fisher AVMs are quite good AVMs to remove. And sometimes you have to come circumferentially, get to the feeder. You cannot make a mistake. One normal vessel you take and one mistake you make in taking a perforator, taking a normal NCA, you kill the person. So it is between life and death, and one perforator and normal vessel between AVM. So this is also another high flow AVM I had done long time ago. And this is the post-operative angiography. See, what I am showing you are the trophies. I'm not saying that I have gone through all these cases without complication and without problem. This is another interhemispheric AVM where I had described first time in the literature contralateral approach. This is the AVM I had done. You see, this was the thing, and I had this side I got the arterial feeder, and then this side I got, and this boy having some weakness in the hand. And this was the contralateral hemispheric approach, which I described in 1995. And then I described bilateral approach, come from here, get to the feeders, and then come on this side and get the nidus. Like this one, you see, you can, if you come from the from ipsilateral side, you can have some trouble with the veins. But to tell you the truth, nowadays I don't use contralateral approach much. Most of the time I come ipsilateral and remove this AVM. This is another AVM in the motor area. I removed this. I created hemiplegia in this patient long time ago. This boy completely alive and fine, comes with a little bit hemiparesis still. Several years ago I operated. You see, these are not cancers. These are not glioblastomas, where the patient will in any case not remain for a long time. You create a deficit, it remains with them for a long time. So you have to be absolutely here. This is height of neurosurgery, ultimate of neurosurgery, ultimate of your understanding of your own skills and your own status in neurosurgery. Another motor strip AVM which I had removed, and this beautifully removed. This AVM patient had come to me in a bleed, with a bleed, and he was quite in a devastated condition. But you see, I operated on this and I removed this. This patient did not survive, but I removed the AVM. I removed this AVM and I took the chance in a patient who was quite a bad situation before operation. You can see this patient bleeding and all. And I removed this AVM because there were some good points. You see, it is being fed by a large ACA, and then there was some other feeders and all those things. I removed this beautifully and he survived for some time, but ultimately did not. I could have left him, but he would not have survived in any case. Velum interpositive AVM. You see, whether you want to do it, these are not such straightforward. You have to have perfect anatomical control of the situation. Perfect. And this had come with the bleed. You see, want to do it, or whether you want to give radiation and all. I will suggest, you see, if you can do it, that is the best. If you can do it, best for the patient and for his life. This is another high flow tentorial AVM which I removed. Difficult, dangerous, jumping in the theater all the time, howling on the nurses and on the assistant, but control, beautiful control of your own self. This AVM, this patient was a mathematician. And this mathematician was embolized several times, and I removed this. There are some 9 aneurysms on the very high flow AVM. Now, this guy I had done some 20 years ago. This man is still teaching mathematics. He keeps on phoning me and asking me some stupid questions, whether I should eat this or whether I should eat that. But he's mathematician. I cannot say don't eat this. And I say, fantastic, as long as you are teaching, you are fine. This is another AVM, posterior circulation AVM, retrograde. You see, difficult retrograde flow, some block here and there. I removed this AVM beautifully. Motor strip AVM. This patient had come from the Union Health Minister, and I started jumping because Health Minister phoned me. And I said, you are the best. And they said that this only convulsion. And this patient I removed surgically, but I created hemiplegia in this guy. And I am still wondering 3 or 4 years after surgery whether I should have touched this guy. The thing is, he was only convulsion, but many convulsions. This guy is still okay, but having quite a severe speech deficit and all. So I did not take a good decision. I removed it. You see, I have this video here, but I don't think I will show you because these videos are not AVM surgery, cannot be shown by videos. I cannot show some fantastic things and say fantastic operation or this thing. You have to show in real. And I have conducted several workshops on AVM surgery, and many of you have participated in that. Another AVM. Now AVM, this motor strip AVM, this patient had come with a bleed. So earlier my but I have now started doing, as soon as it bleeds, you see that patient is hemiplegic. So I take that advantage and I operate, because if you create hemiplegia, then the person was already hemiplegic, you have that excuse. But if this patient had improved, this patient will 100% improve. With this bleed, hemiplegia will improve. But now I operate early and remove this AVM early because of some little bit, insurance that it provides. Also, you must remember that Complications can be devastating. Complications can be absolute. So you have to be absolutely sure that you can give this beautiful smile to this guy, and to this guy also who has operated him. You see the smile of his is better because this is a trophy, is a height of microneurosurgery. You want to take it, you want to leave it. My request is, my recommendation is, AVM is a surgical issue. AVM is a curative issue. AVM is a dangerous issue. We have to learn to live difficult life. We have taken neurosurgery as a because we love difficult things, but we cannot be foolish. AVM neurosurgery is not for foolish people. It is for intelligent people. You have to know when you can remove. You have to know when you cannot remove. You have to know your own skills. You have to know your own stature, and you have to know large vessels. You have to know small vessels. You have to know how to control big vessels. If you know how to control small vessels, you have won over AVM. But that I will not tell you the trick how to control small vessels, because it is not such an easy job. AVM which have been embolized, do they make your surgery easy? Absolutely no. Embolized AVM, I work in an department which is well known for interventional radiology. For many years, we had one stalwarts of Asian stalwarts in India, and in India, working in my department, all my AVMs were embolized. But I will say, my opinion is, I will operate, of course, because many of these are embolized, but I don't get terribly happy when they are embolized. This is another AVM, heavily embolized. I removed it. Intraventricular AVMs are much simpler and much better. Temporal Horn Avm. This is another intraventricle. You don't know whether it is inside the ventricle or outside the ventricle. Inside the ventricle, easy. Outside the ventricle, dangerous. You see this AVM looks like lenticulostriate artery, but many of these are choroidal arteries. Choroidal arteries are easier to operate. Pile AV fistula looks dangerous, but they are the simplest, even better than a burr chronic subdural burr. These are better. You come here and get this artery and matter is closed. But that time I didn't know, so I removed the whole thing. It is not necessary to remove the whole thing. Like this, in a small child, I just clipped this anterior artery like a burr, and this patient is absolutely fine. So pile AV fistula is a different world, easy world. You should know these entities. Many AVMs don't touch it, because normal life history is better. Some of these AVM, I say, gentlemen, my dear friend, take it easy and let me live easy. This is AVM in the thalamic area. Don't touch it. AVM near the brainstem. Don't touch it. If you can touch, you can touch. But in my definition, they are not safe. And in my classification, not to be done. These kind of AVM. This AVM, I'm still wondering whether I could have done it, but this is still dangerous. So many AVMs should not be done. Now, just last word about embolization, whether it is good or whether it is bad. I don't think it is absolutely of value, but recently I'm hearing many articles from many presentations during the COVID times that embolization is good and this and that. I can do, and I can do. So I'm a little bit confused. So my confusion remains, and I leave it to others in the panel to solve this confusion for me. Thank you very much, my dear friends.
Thank you, Professor Goel, for giving an clear idea of which AVMs to operate and which not to operate. As I understand from you that no patient should go for radiosurgery, but we have Professor Manmohan Singh from All India Institute to speak on when he will take over the cases you have left out and in eloquent areas. I request Professor Manmohan to start his lecture.
I hope you can see my screen.
Yes, yes.
Yeah. Okay. Good evening and good morning to people in the various parts of this globe. So after Professor Goel's talk, I think it is very difficult to counter him with regards to the radiosurgery, and that too for the eloquent area AVM. Let's see that how can I justify my talk in front of Dr. Goel. So as we all know that there are different options for AVMs, which include microsurgery, embolization, stereotactic radiosurgery, and a combination of microsurgery, embolization, or the stereotactic is there, so that we can have the optimal outcome in the long go, and to reduce the complications so that our patient is intact with the minimum number of complications and he can have a normal life. So there is no controversy for the radiosurgery for the eloquent area. Over many years, the radiosurgery has emerged as the mainstay of management. The surgery do remain the gold standard for the grade 1 and grade 2 special Martin in the non-eloquent regions, that too in an expert hand, so like Dr. Goel. So for the eloquent region AVMs, the radiosurgery is the treatment of choice world over with acceptable complications. We must accept that there are likely to be some complication in each modality, but that complication has to be minimal and those complications should be acceptable. So what are the eloquent areas of the brain? The eloquent cortex, like motor, sensory, visual, and speech areas, is not only the eloquent cortex. We always forget that the deeper part of the brain, like internal capsule, thalamus, hypothalamus, brainstem, chiasm, and the deep cerebral and the cerebellar nuclei, they are too eloquent. So any damage to either of these structures can lead to the devastating complications. So we must respect these, and so that because once we operate, once we embolize, once we do the radiosurgery, if the complications happen, so this patient has to bear for his rest of his life. So we must make sure that we are not going to leave a person devastated with all our heroic measures in either of the modalities. So any intervention leads to the altered AVM hemodynamics, which may result in severe neurological deficits, which are maybe the immediate or the subsequent risk of hemorrhage, and the significant morbidity and mortality. So the various authors have given different statistics for the surgical outcomes. Let's talk about the statistics. So, So the various authors, they have reported the different statistics, like the reported disability around 11% in first author and the mortality of 5%. Another author has given the disability of around 11%, with 61% patient had the reduced capacity to the work in eloquent area AVM post-surgery. Heroes et al. Has reported around 8% morbidity and nearly around 0.5% mortality rate. Another author has reported around 6.1% of the permanent significant neurological deficits following microsurgical removal of small AVM, even the small, the word is small for AVM for the eloquent region. So we always have the bias in our treatment. So the management is mostly biased toward the modalities available in-house. The neurosurgeons in the division centers do choose modality as they are good at, whether it is a surgery or radiosurgery, for every case, whether indicated or not. So this is we must keep in mind, if we have the all modalities available, we may do justice for those patients. So why radiosurgery? So microsurgical excision of AVM in eloquent regions is always reported with significant morbidity and mortality. So embolization is associated with morbidity unless aimed at an adjunct treatment, either for embolization, either for surgery or for radiosurgery. So radiosurgery is associated with a relatively very low morbidity and rarely mortality. How does radiosurgery work? So we should all know about it. So the radiosurgery is gradually evolving radiation effects to obliterate the radiation AVM nidus, because of the effect of radiation to the intima of the blood vessel in the nidus. They gradually get damaged over a period of time and lead to the thrombosis of the vessels inside the nidus, which lead to the progressive obliteration of the nidus over a period of time. So this gives brain tissues a wide time window to adapt to a new hemodynamic. So that's why the AVM and the brain adapt to such situation in a better way. And the brain also tolerates side effects better due to the longer latency for its effects. If we look at the radiosurgery results, the results vary depending on the dose and the volume of the nidus. The slow obliteration in the SRS needs longer follow-up, and so that we come to know that what is the outcome. If we look at most of the series world over, though follow-up is not longer, it is hardly around 3 to 4 years, or even less than 3 years, and then we come to the conclusion that that the SRS is not working in such patients. So to look, most of the AVMs, they obliterate, if they are going to obliterate by the end of 3 to 4 years. But few AVMs, they do take longer time, nearly 5 years, and sometimes maybe a little longer for the obliteration. So we need to be patient. So no doubt during this obliteration time, the patient may have the risk of rehemorrhage during this time. But this hemorrhage statistics is definitely lower as compared to the natural history, according to the newer studies. So Flickinger documented an obliteration rate of 73% overall obliteration. Then another author reported an overall 70% obliteration rate. And for the AVMs with the volume of less than 3 ml, that is a very small size AVM, the obliteration rate was significantly higher, up to around 87%. At our center at AIIMS Delhi, we have around 85% overall obliteration rate for the smaller AVMs. So we'll look at these AVMs. So this is the thalamic and the hypothalamic AVM. Can we think of treating such an AVM with any sort of surgical excision or with that embolization? It is no. You look at there, this AVM is gone. So this is a case of basal ganglia and the bithalamic AVM. You see that this is a diffuse nidus. This is practically gone, very small residual in the follow-up, which is, if you follow it up further, it is likely to disappear. So another motor stiff AVM. So patient is practically only presented with seizures. So surgery has got its own complications, which many times we fail to document whether the patient had developed some deficits, because only few gifted surgeons can do it in a better way, because the surgery is on a decline and the skills has gone down. So you look at this post-procedural angiogram, this as if there was nothing in this angiogram. So practically disappeared. So we have some sort of complication. If we look at because the most devastating complication following any treatment is the rebleeding. We should always talk about that. So the rebleeding is there. So rebleeding following radiosurgery, post-radiosurgery procedures varies between the 3.4 to 10%. And in the centrally located periventricular or the deeper AVMs, the rebleeding rate is little higher. The rate is higher because we sometimes tend to reduce the dose of radiation in such places, because in the basal ganglia and near to the brainstem, near to the chiasm, and because we tend to reduce the dose, that's why the rebleeding rate is little higher. So in one of the authors, he has documented that the basal ganglia, internal capsule, and the thalamus, the reported hemorrhage rate is nearly 9.5 in the first year and around 4.5 in the second year, and thereafter it is practically zero. It all depends on how longer we have actually followed up these patients. So what are the risk factors for the bleeding? So the venous ectasia, stenosis, hypertension, and the presence of the intranidal aneurysm, these are the major risk factors for the rebleeding following any radiosurgical procedure. And in our experience, we feel that the early venous occlusion, because if the patient has got a fewer or the single draining, if that veins get stenosed early due to the radiation, that the risk of is higher. So that's why we need to have a better plan so that we keep those veins away from our radiation target, so that the veins do not occlude first, so that the risk of rebleeding we can reduce in the following days. So the lower marginal dose reduces the complication, but it also decreases the obliteration rate, and the risk of rebleeding in such cases may be higher. Large volume nidus, we tend to reduce the dose again, so the risk of rebleeding may be more. So radiation dose, the more the radiation dose, the more is the obliteration rate and the less is the rebleeding. And the prior hemorrhage is an indicator that these AVMs are already unstable, that are likely to bleed in future, even the post-treatment. Because of the window period of this radiosurgery, this hemorrhage may happen. How do we prevent? So I have already told that avoid including the draining veins in the radiation field. We need to have a very crisp plan so that the draining veins are away from the radiation field, which we can easily achieve during this planning. So the appropriate radiation dose has to be chosen so that the AVMs are targeted well and they respond to the radiation, and even the radiation respond to this radiation dose in the long way. And the fewer centers during the planning, the dose or the volume fractionation. If, for example, if AVM is in the eloquent areas, motor stiff, into the chiasm, into the brainstem, So even if it is smaller, so we cannot give a full 24 to 25 gray in a one go. We need to do the dose fractionation. Or in the another way, if the volume is more, so like the large AVM around 20 cc or the 30 cc, so then we have to do the volume fractionation so that we may have to divide the AVMs into 3 or 4 segments. So each segment is given radiation dose at a different time period. For example, in one segment is we are irradiating at today, and next segment in after 6 months, and then a year or later, so that we reduce the complication and increase the obliteration rate. So another important point, we all as a radiosurgeons feel that the 12 gray line of the normal brain volume should be less than 10 cc. In another way, so if we draw a 12 gray line around the nidus, so that the normal brain should be the measured less than 20 cc, so that the complication of the radiations are less. And we have to make a as conformal plan as possible so that the complication is less and the radiation spill to the surrounding normal brain is minimal. So it is always a balancing aspect of the radiation dose. So we have to balance between the obliteration rate as well as the adverse radiation effect. So this balancing is very important depending upon how much dose we deliver to the given AVM. So another aspect is the adverse radiation effects. So many times these adverse radiation effects are transient. If we give a radiation to eloquent area AVM or AVM elsewhere in the brain, so we always see some sort of radiation changes surrounding the AVM nidus in the follow-up period. If we do the imaging like the CT scan or the MRI after 6 months or 1 year, you will always see some sort of radiation change. But most of the patient, majority I would see the treatment of the 90%, so they are asymptomatic. So they need not to have do anything. So only thing is that just wait, and these radiation effects or the changes on the imaging, they will disappear. The irreversible symptomatic ARI are common in the brainstem. They are common in the brainstem as well as the thalamus, as compared to the hemispheric AVMs. So the majority of these symptomatic AVMs, the adverse radiation effects, they respond well to the steroids, vitamin, pentoxifylline, or in a rare situation, we need to add the bevacizumab. So the surgery is needed in less than 2% of the radiation necrosis or the cyst formation, because if the patient has developed radiation necrosis with the surrounding significant mass effect, and rarely these patients need surgical excision, so that all the necrotic part is taken care of, or if the cyst formation is there, which is causing pressure effect. So the most of these patients, they really respond well. You have to identify these patients early and have to offer surgery in such patients at an appropriate time, so that a very good outcome is expected out of them. So risk of radiation injury, as I have already told, that increases the size of the lesion and the radiation dose. Actually, risk of radiation toxicity is 2 years following radiosurgery is around 30%. And this is all radiological, and clinically they are, majority of them are asymptomatic, and these spontaneously resolve. But the symptomatic toxicity is less than 10%. So this is, for example, you see that first image, you see that there's a motor strip AVM, and there is significant radiation changes surrounding this event. This patient was mildly symptomatic with some sensory or the mild hemiparesis, and there is no mass effect. You see that, but you wait, start on steroids, these changes will practically disappear in most of these patients. So in second image, this is a significant mass effect in such patients, and this patient was embolized earlier also, and it is not visible here, but this patient had cystic changes around this nidus. So this patient required surgical excision because of the mass effect, and the patient was worsening. And the post-surgery, this patient did well. And this is a case of radiation necrosis. So this patient also needed excision. And these are the rare cases. And practically we will see less than 2% of these all radiosurgical cases. So another cases of the motor strip AVM, you see that the AVM, based on the T2 images, that there is no nidus, or you can see that no flow are seen. But this patient developed cystic change, required surgical excision, and this patient improved significantly with minor deficits. So you have to identify these patients early so that you can offer surgery in such patients. And again, I will reiterate that these cases are very minuscule number of cases in overall gamut of radiosurgery. So how to reduce reducing dose decreases efficacy. I know I have already explained that. The dose fractionation for even smaller AVMs, if the 12-ray line volume of normal brain exceeds 10%, and the volume fractionation for the large AVM, and surgical excision of small residual AVM with this formation is the mantra for a good outcome. So you can see that this is all diffuse AVM involving the left temporal, occipital, and the parietal region. So in any standard, this patient had significant headache, persistent intractable epilepsy, and no doubt this patient never had a bleed, but this patient was having the suicidal tendencies also. So what to do then? We planned volume stages in post-AT. You practically see that this disappeared. Very small residual, which is likely to disappear in the following year. So you just need to have a regular follow-up. So this untreatable situation is a treatable one now. So what is the future? With the improving imaging and the treatment planning, with the new techniques and the ever-improving, newer equipment, we can have the better obliteration and the lesser complications. Surgical skill in AVMs have declined. We have to accept that word over. Very few people are now AVMs. And these skills are difficult to reproduce across the different centers and the surgeons. The radiosurgery is easy, planning is easy and reproducible across the center. This is very important that in most of these radiosurgical procedures, they can be done by each and everybody. And the surgical resection is complementary to SRS for the small residual AVMs and the radiation complication for the optimal outcome. I hope that I proved my point, and it is open for discussion later. Thank you.
Thank you, Professor Manmohan, for teaching us the indication as well as the complications and how to manage the complication. And hope Professor Goel will agree on it in the panel discussion. I'll request Dr. Clemens to introduce Professor Pascal and invite him to give the talk.
Yeah, thank you very much. So it is, again, my distinct pleasure and honor to introduce one of my good friends in neurosurgery. Professor Pascal Jabour is a professor of neurosurgery at Thomas Jefferson in Philadelphia in the US, and really is also leading the cerebrovascular division there, is really well known and will educate us hopefully on the multimodality treatment of AVMs. So thank you very much for being here, and hope to learn from you, and let's go.
Thank you, Clemens. Thank you for the committee. It's a great pleasure and honor to be here giving a lecture between all the experts. I can say I'm going to be the one standing in the middle, holding hands with the three other speakers and do kumbaya and tell you that not one of the speakers is completely right, but the three of them combined are right. So it's not a competition of the tools, but it's all the tools against the disease. So those are my disclosures. So we can talk about AVMs without a little bit talking about Aruba. Once upon a time on an island in the Caribbean was Aruba. And as you know, this trial was so controversial. And the results, we were all surprised, and we weren't happy with it. But if you look at it, there are some good things and some bad things in Aruba. And there were a lot of editorials. And then what did we learn? So there were some concerns, and the main concerns were there was a generalization that one treatment method is equal in complexity to the other. And here we're comparing open surgery, stereotactic radiosurgery, and embolization. We're comparing it to something that's very homogeneous, which is medical treatment, it's not practically medical treatment. It's just watching and not doing anything, which is a lot of times that's the right way to go. So, they didn't differentiate in grades. They didn't differentiate in high risk features like aneurysms, etc. And then only 5 patients had surgery. As you know, surgery is the only treatment where you do it and that's it. The patient is cured, immediate cure. The rest are multiple embolizations or stereotactic radiosurgery where you're going to wait 2 to 3 years. 20% had feeding artery aneurysms. What should we do with those? And then the short follow-up period, we're talking here 33 months. Can we judge of the natural history of an AVM if we watch it for 33 months? You know, if at 33 months it didn't rupture, it doesn't mean it's not going to rupture. It's as if you're talking about treating an unruptured aneurysm on a patient with cancer. The first thing you do, you pick up the phone and you call the oncologist and see what's the life expectancy of the patient. So if they tell you the life expectancy is 33 months, you're going to think about it. So don't let AVM intimidate you. And a lot of times they look really bad and horrible. Like earlier, Professor Goel told you, like sometimes it's very simple to treat them and don't just be scared. But at the same time, you should know your limits, and not every AVM, you're going to jump on it and try to fight it. And if anything, Aruba taught us that, to know our limits and to know that our treatment modalities carry risk. So we have here, you know, different options, and I'm in a situation where I can talk about all those because I practice all those: microsurgery, embolization, stereotactic radiosurgery, and then watching. I know how to watch AVMs very well. This was one of our early papers where we looked at 264 cases of AVM resection that we did. And of those cases, 38.6% had gone prior embolization. 12 patients had underwent gamma knife prior to surgery, and the severe morbidity was 1.9% in the series, mortality 2.7%. This was a series combined of ruptured and unruptured AVMs. 86.4% were discharged home. And then the most important thing that also you saw with Professor Goel's presentation, complete obliteration is 100%. This is a technique where you go in, you resect the AVM, that's it. It's not coming back, it's gone. So 45% were ruptured, 120 of the patients. And this was the Spetzler-Martin grading of the AVMs that we've operated on. So the majority were 1, 2, 3, as you can imagine. 9% of grade 1, 45% grade 2, 34% of grade 3. And there were some high-grade AVMs. So the patient's outcome and predictor of complications were increasing number of embolizations. So patients that had pre-operatively an increasing number of embolization, this was associated, odds ratio 1.6%, to have a bad outcome. And we know literature, the rest of the literature show that too. Increasing AVM size, of course. Unruptured AVM at presentation, well, this is a little bit tricky. It's because you can really hurt those patients because they are completely intact, as compared to operating on a ruptured AVM, they have already deficits. So as I said earlier, in all those patients, you know, we had pretty good outcome in obliteration and in patients remaining neurologically unchanged postoperatively in 92.4%. And an example of where we used to combine multiple embolizations and then took the patient to the OR. As you see here, we embolized first, then took the patient to the OR and resected the AVM. This makes it, you know, much easier and faster to do. Again, identify your anatomy, identify, of course, your draining vein that you're going to keep until the end, master the microsurgical skills, the microvascularization of the AVM to have a good outcome. And then at the end, we always do, of course, an intra-op angiogram to confirm and make sure that everything is out. And that's at the end. We clamp the vein and we cut the vein, and that's the AVM. And this is the intra-op angiogram, another case of an AVM. Again, at the end, intra-op angiogram. And more with functional MRI and tractography, we can have a lower, we can assess the surgical risk better and give the patient an idea what would be the surgical risk. Patients presented with intercerebral hemorrhage, mass effect. Here, we don't have any, no question, no choice. We have to take the patient right away to the OR. Like this patient, we did shot an angiogram on the table with a C-arm, not the C-arm, on the hybrid room. Before the hybrid room, we used to shoot them on a C-arm. And then here it is, we're evacuating the hematoma, and then the AVM is resected, pre and post, intra-op angiogram, all the time. What about embolization? So there are a lot of advances in embolization, and this is different than 10 years ago or 5 years ago, and even different from the time of Aruba. There are the dual lumen balloon macrocatheters that let us really decrease the reflux of the liquid embolic. There's the detachable tip catheter where we can tolerate more reflux around the catheter. There's the new techniques of venous embolization, transvenous embolization, and pressure cooker technique. This is a catheter that with a detachable tip, the catheter with the balloon, dual lumen balloon, the pressure cooker technique, which is inflating balloons from the arterial side, putting a coil from the venous side, and then creating a closed circuit, and then injecting your liquid embolic. Balloon microcatheter, dual microcatheter balloon catheters are really the way to go. No reflux, you can inject really quickly, and then you'll have everything all the way going to the vein, and you won't have any angiographic cure unless you really go push your liquid embolic completely to the vein. You don't want to occlude proximally. This is a patient that presented to an outside hospital with a subdural hematoma, and then turned out that she had this AVM where we went with the balloon, the Scepter microcatheter, dual lumen balloon, and then that's the angiogram. Another case of a patient that presented with a little bit of subarachnoid hemorrhage and a seizure, has this AVM. Same thing, dual lumen balloon technique. You see liquid embolic should go all the way to the vein to be able to say, yes, it is angiographic cure. Now, you need to have long-term follow-up really to say that the patient is cured. It's also controversial. Some would still resect it. But again, as long as you have a long-term follow-up, we have patients up to 5 to 10 years follow-up with no AVM after embolization. This is a case of transvenous. The patient came in with the IVH, and this is the AVM, pericallosal AVM, one draining vein, that's a straight sinus. We decided to go transvenous on this AVM. Went in transvenous. Those are the microcatheters from all the feeders with the balloon microcatheters to create the pressure cooker technique. As you see, multiple microcatheters. We inflate the balloon to decrease the flow in the AVM for the liquid embolic to stay in the nidus. We put a temporary coil on the venous side to also decrease the shunting. And then you're gonna see from the venous side, we started to inject the liquid embolic that's gonna progressively toward all to filling the nidus and toward all the feeders. Here it is, going progressively. The glue cast getting bigger, and this is finally what we have. Then we're gonna do super selective injections. So this looks good. Then we do from the arterial microcatheter super selective injection. We see some shunting here, and then we can finish it from the arterial side. And this is the final result, complete obliteration. This is another case of a patient that presented with a hemorrhage, had a decompression at an outside facility, but they didn't touch the AVM. So the patient was transferred to us, had already a decompression, hematoma evacuation, but they didn't do that. They didn't resect the AVM, and here it is with the balloon-assisted embolization of the AVM. What about the radiosurgery? I think Dr. Singh, Professor Singh, had a really nice, outstanding lecture about that. And as you already saw, that the response rate will decrease with the volume of the nidus. This is the physics behind it. And now we have more new fusion software. This is the new Element software from BrainLab, where you have really nice fusion software where you can do all those without even a frame for the patient, and you can fuse CTAs, MRAs to angiograms, and then choose your target. So if your surgical morbidity is above 12%, mortality above 4%, maybe radiosurgery is a good option. It's a little bit tricky for patients that had previous embolization. This is our series of complex AVM who had already a previous embolization. We know from the literature and from UPMC that those have a lower risk of response to radiation because it's a little bit confusing what will be your target. So we looked at 95 patients whether that had stage embolization and had stereotactic radiosurgery after that. And then overall morbidity was 13%. Post-treatment ICH was 4%, so this is not benign. And then 10-year angiographic cure is 63% as compatible with the rest of the literature. Negative predictors for cure, large AVMs, deep venous drainage, increased number of embolizations. So we see this, that's a recurrent theme, increased number of embolization and increased number of stereotactic radiosurgery. So with time, your obliteration rate will increase. Nice angiographic results. So this works before and after. And again, as you saw early, the complication rate will increase with the dose. This is a patient that had a cure of her AVM and then developed really bad radiation necrosis. We ended up decompressing her, then she developed an abscess. Post-stereotactic radiosurgery, cyst degeneration, we see it sometimes. This is a patient that's cured from his AVM but developed that. I treated him with a cysto-subarachnoid catheter, shunting, and then he did well. Sometimes not doing anything is the answer. This is the patient came in, originally saw me with this, then went and then never followed up, had this really bad AVM with a Fistulas component. Came back with the right hemiparesis and aphasia. We got a CAT scan showing he never had embolization. Those are calcification. And as you see here, he had some hemorrhage, but they were all thrombosed veins. So this patient was thrombosing his AVM spontaneously as we speak. This was when he was at the hospital. You can see a little bit some shunting here. And then I brought him for a long-term follow-up, and that's the long-term follow-up. Practically, this patient didn't need my skills or anybody's skills, and then he occluded his AVM. We did a 1-year follow-up. It was still occluded. Smoking is a negative predictor for arteriovenous malformation obliteration, regardless of the technique used. We published this on 774 patients. So like aneurysms, very important to tell our patients that. So as a conclusion, as I said, I'll be the common ground between the three speakers at this point. We know that the natural history of brain AVM is not benign if you follow them long enough, and this is definitely more than 33 months. We definitely need to bring our M&M very low, regardless of the technique we use. With new endovascular and stereotactic radiosurgery techniques, we are able to cure more AVMs. Definitely, we need to stay open-minded, not one technique. It's a tailored procedure. Not because we have the tools, we have to offer treatment. It's very important, not because I can inject some glue, I can go and inject some glue and decrease the size and say, oh, you're fine, because we're not doing any favor for the patients. Very important to have a plan. We need to have a plan from the beginning. We cannot say, let's start our first session of embolization and then we'll figure it out. No, we need to have a plan. Am I going for a full cure? Am I going for a pre-op embolization? What am I doing? And sometimes we can't beat the beast, so we'd better just watch it. So again, it's not a competition. It's all the tools against the disease. And like everything else, it's very important to be accurate in everything you do and you say.
I do. The groom is already married. He married me 3 years ago. And don't let him deny it. I've got the marriage certificate to prove it. Sorry, wrong church.
Thank you.
Yeah, thank you, Professor Pascal, and for explaining the multimodality management, and the endovascular procedure was really exciting and very interesting. And we will still have interesting videos from Professor Srinivasan, who will speak on embolization in eloquent areas, and he does it with intra-op monitoring. So I request Professor Srinivasan to start his lecture.
Sorry. Good evening, everyone. Thanks, Dr. Manas, for this wonderful introduction, and thanks for the opportunity. And after the 3 great talks, I'm going to start on talking on the endovascular management of the brain AVMs. I'm sorry, I'm just trying to figure out. Yeah. Oof. I'm sorry, I'll just come back. I'll stop share. I'll come back. I'm having little difficulty with the share. So. Okay, I think now the screen is okay. After the three great talks, I'm just going to throw some light on the role of embolization in brain AVMs. I was so surprised to hear Dr. Goyal saying that he was confused about the role of embolization. I've never seen him confused over the years in many of the talks I've seen him. And either I will confuse him more or maybe clarify some of his doubts with this talk. Okay, with this talk, I want to answer certain questions. Is there a role for embolization? Is there a progress in endovascular treatment for brain AVMs? And can we cure AVMs with embolization? And does pre-op embolization or pre-radiosurgery embolization work? And is there a role for partial embolization? Can you treat AVMs without embolization? So these are the questions I want to answer. From the endovascular standpoint, I want to reiterate some of the facts, how we look at AVMs before we decide on the multimodality treatment. From endovascular standpoint, we either look at them as a superficial or deep based on this arbitrary circle, which runs through the circulus sulcus, cingulate sulcus, and callosum sulcus. And the reason is that the AVMs that are superficial are the part of the AVM that is superficial have feeders from outside in, the part that is inside have feeders from inside out. But the venous drainage does not follow the same pattern. The venous drainage over the cortical region drains outside, anything below the cortex drains inside. And we also look at AVM from a different angle. It's a venous disease. Practically, it's the vein that drains out and then a bunch of feeders that goes into the vein, and they may have multiple feeders into it. If you look at it from this angle, the compartmentalization of AVM becomes fairly simple. It may have a single compartment or may have a multiple compartment like this. And compartmentalization of AVM is important for endovascular embolization. The arteries may have various compartments, but the venous compartments are much more important because we are trying to cure an AVM by going into the vein and trying to embolize and obliterate the veins. That's when a cure is achieved. So venous compartmentalization is much more important, and they do not follow the same pattern as an arterial compartment. For example, this AVM has got about 3 feeders, which is arterial compartment, and 2 venous compartments. Apart from looking at an angiographic picture of an AVM conventionally thought about, that is having a feeding artery aneurysm, the nidus, diffuse, plexiform, having a superficial deep venous drainage. Some of the AVMs have a pattern. Endovascularly, when we explore an AVM, they have a pattern, and understanding this pattern is extremely important to know your limitation, how much you can embolize, when you need to back out, when you say that I cannot embolize this AVM, and you have to look for alternate opportunities. Being a surgeon myself, I explore my own AVMs and then decide what is the best option after a thorough angiogram. For example, a sulcal AVM, which is external to the practically the gray matter, and most of these AVMs will have end feeders and have a single draining vein. And if you take an angiographic picture, the blood vessel will end in the AVM and will have a single venous drainage outside. These are some of the examples of sulcal AVMs. You can see the cortical mantle intact, compressed, and pushed away. Whereas the gyral and parenchymal AVMs are the most common AVMs, wherein it's below the cortical mantle, and it will have penetration deep inside. It will have multiple feeding vessels. They may be the perforating vessels coming from the cortical vessel, or they may have lenticulostriates arising from the deep. When you superselectively catheterize and inject and study these AVMs, they'll have these kind of perforators, and they'll usually have multiple venous drainage. And if these perforating vessels are large enough, you'll be able to embolize, but most of these AVMs are treated either by multimodality treatment or with surgery. Coming to the next step is the PL fistulas. PL fistulas, Dr. Goyal was showing some of the cases. These are high flow situations. They may be on the surface, which can be treated either with surgery or by endovascular means. If they are deep in the brain, they need to be treated by endovascular means. Some of the AVMs, plexiform AVMs, do have fistulas in them. When we endovascularly explore them, you can see that they are deep and they have like a fistulous nature, and they lead to multiple venous aneurysms and wide channels. You can endovascularly embolize them because these fistulas are not amenable to radiosurgery if you're planning radiosurgery following embolization. Apart from that, we also have to look at the cisternal AV fistulas, which are the high flow fistulas, which are predominantly seen in children because of the high flow nature. And these are vein of Gallen's. Then you have the various quadrigeminal cistern, kind of a PL fistula occurring in the basal cisterns as well. So vein of Gallen is a different set of a disease which needs to be treated in a more aggressive fashion by endovascular means. You don't have any other option for it. These are kind of cisternal fistulas, which are multi-hole fistulas, which we see at the basal cisterns, and they can be effectively treated by endovascular means. So these are the patterns of AVMs that we usually see. When you come to the feeders, when you assess, they do have a pattern. It is either an end passage feeder, as you can see in this picture, the main vessel going in to supply the normal parenchyma, and there are smaller branches that comes off it to supply the AVM. This is one lenticular striate artery which goes on to supply the thalamic region, but on the way it supplies an AVM. There's an MCA branch which goes on to supply the cortex and has end passage feeders. These are not favorable situations for embolization, whereas an end artery, end feeder like this is a favorable situation for embolization, and you can pump in your liquid embolics to completely obliterate this kind of AVM. You should not confuse an end passage feeder with the perinidal angiogenesis, which are quite common, and you should understand these perinidal angiogenesis are secondary reactions, and they will usually involute after treating the AVM properly. Or during surgery, you can just remove the AVM and these will involute. And you also look for the dural feeders which come from the surface, and they are in certain situations useful because they enlarge over a period of time as you sequentially embolize, and you can achieve complete obliteration through these feeders. As far as the embolizing agents are concerned, our concept of embolizing agent has changed. We now use either glue or onyx or DMSO based other liquid embolic agents. Initially, they thought that if we embolize the junction of the artery and the nidus, it's okay, but not anymore. We need to obliterate the nidus and the venous origin. That is when we will achieve obliteration and cure from an AVM. NBCA or the liquid embolics are rapidly embolizing agents, which we use very commonly. This is a real-time glue injection, as you can see here. As the glue flows through, it fills and rapidly polymerizes, and then when there is a reflux, you immediately pull out your microcatheter, and you'll have to look for other pedicle to progressively embolize. Whereas Onyx is a DMSO-based liquid embolic agents. As you inject into the blood vessel, the DMSO gets washed out and the surface gets solidified, and the inner core is still liquid, and you can push it far and wide like a lava into an AVM, and you can achieve good obliteration, multi-compartmental obliteration when you use such liquid embolics. Here's one such example of onyx flowing through an AVM. Your microcatheter is far posterior. As you can see, you can just go far and wide, and you can just keep obliterating different segments of an AVM. As far as the microcatheter technology has improved so much, we had the flow guided catheters. The Magics are wonderful catheters. You can really reach into deep AVMs and like far away AVMs with ease. And the game changer in AVM treatment has been the detachable tip microcatheter, as Dr. Jabbar just spoke about it. The Sonic and Apollo microcatheter, compared to Apollo, Sonic microcatheter has significant advantages, and it is one of the game changer according to me. And we are able to achieve more and more a cure with embolization because of this detachable tip microcatheters. Obviously, the balloon microcatheters are a useful tool, and I predominantly use it for the dural feeders. This is a flow guided catheter, as you can see here. I'll just play this video. You just follow this dot. My micro wire is here. Just with the flow guided, I'm just going through 3 different sulci and going deep into the AVM, and I'm able to get really close to this AVM. That is the success that I can achieve for embolizing this AVM, is the successful microcatheterization. So what exactly is the role for brain AVM with embolization is that you can either look for a cure, or you can use it as an adjunct preoperatively or pre-radiosurgery. You can do a target embolization, and in certain AVMs, it has an optional role. With or without embolization, you're still okay, you can embolize it. And there are situations where there is no role for embolization. So you have to judiciously choose it. And I do this with the caveat saying that do not randomly embolize an AVM without a plan. Partial embolization, random embolization is a real no-no for an AVM. When AVM embolization is done in a high volume center in properly selected AVMs with multidisciplinary team analysis and discussion with a definite treatment plan, the complication rate with embolization is extremely low. And cure with embolization is achievable in about 1/3 of the AVMs, and usually in about small and medium-sized AVMs with low morbidity and mortality. This is one such case of detachable tip microcatheter that was used for onyx embolization for an occipital avm. This is the microcatheter injection. You can see 3 different veins. This is how we fill onyx. First, it goes into one of the vein, we stop, we inject, it gets into a different compartment, we fill different regions, different feeders, and it gets into another vein, and then we stop, and then finally we inject, and it also gets into smaller collaterals, and we fill the entire avm. This was before embolization. The vertebral and ICA runs. This was post-embolization with complete cure achievable. And you have a lot more leeway with these detachable tip catheters because you're not worried about your catheter getting stuck, and removing the catheter is no more a significant problem. There's another case which was treated with the magic microcatheter. This was a young girl who presented with a cerebellar bleed, initially decompressed and external ventricular drain done, and she recovered quite well. And in about 3 weeks, we spoke about doing an angiogram and going for surgical resection, but she was hell-bent on not having another surgery. So this AVM was far away and wide. I would have done it with surgery quite well, but she wanted to be done endovascularly. So we went ahead with the microcatheter, magic microcatheter, got all the way up to the nidus. All you see here is the venous channels going off the AVM that was embolized with glue. I can keep showing examples of various AVMs. This is a deep-seated AVM. As you can see here, has supply from lateral ventricular striate, and the other larger one, which is even lateral. This is a super selective injection. As you can see, the AVM has an intranidal aneurysm, and you need to get far and deep into the feeder that goes into the AVM, avoiding obliterating the blood supply to the normal brain matter. So you need to do this, and you can do neuromonitoring using sodium amytal or phenobarbital. And you can also inject lidocaine to look for the white matter fiber tracts and make sure there is no drop in potentials before you embolize these AVMs. As you can see here, glue was injected with complete obliteration. This was a 17-year-old with a spontaneous intraventricular hemorrhage. There was a small AVM with the intranidal aneurysm that was embolized. So after the angiogram, in the next 30 minutes, you're done treating this AVM. This is another 1-year-old child presenting with a choroidal AVM, present with an intraventricular hemorrhage. This was a choroidal AVM. Our catheter technology has improved so much, and we are able to get these catheters without putting the wire up front. As you can see here, this catheter climbing up beautifully, very close to the nidus. You get it close to the nidus, and then you inject glue in various concentrations. Based on the flow pattern, you can also achieve hypotension to specifically located in the region where you want. And the cure was achieved with single pedicle embolization. And this is another thalamic AVM which was treated. The most important thing is you need to get the glue cast like your angiogram. This is an angiogram, and this is a glue cast. The glue cast has to nicely fill in the nidus of the AVM to achieve cure. And then the cisternal AVMs. There are quite a few cisternal AVMs which usually have these kind of micro feeders. You need to be patient. You need to understand the disease. You need to get to the nidus. You need to super selectively catheterize, inject, and they are all obliterated with glue injections in various concentration. And they are usually done in about 2 or 3 sessions with 3 or 4 catheterizations during each session. And if you're able to achieve this kind of a embolization, you'll be able to cure these AVMs. This was one interesting case which really changed the way, I look at the occipital AVMs. This was a 35-year-old female who presented with an occipital intracerebral hemorrhage during the 2nd trimester of her pregnancy. And she had a bleed, and I offered her surgery, but she refused. She went, she had a visual deficit, but she was okay with it, and she had mild headache. She did not want to have a surgery, and she had this kind of a visual field which gradually recovered. She went on to deliver by C-section. 3 months post-procedure, she came back and told me, can you treat by any other means apart from open surgery? Then I decided, okay, let me embolize it. And through 3 pedicles, we were able to embolize completely. And she remained intact, and her vision remained intact. With surgery, most of the time, there was a high chance that I would have given her hemianopia, but I was able to embolize this AVM, and subsequently I've done about 3 or 4 AVMs in a similar location, relatively more deep-seated, preserving vision and without any visual deficit. This is one posterior thalamic AVM. As you can see here, these are small little bunch of AVMs which drain into an enlarged vein of Galen. This is not a true vein of Galen. This is a vein of Galen enlargement. You super selectively catheterize, inject, and embolize to achieve cure. This is a patient who presented with the third nerve palsy with headache, and he came to us at about 6 weeks following the bleed. He had a midbrain AVM which is bled. He had a residual third nerve palsy, and this was the AVM. And obviously superselectively catheterized, neuromonitoring was done, and there was no drop in potentials, and we were able to embolize this AVM again with glue, and we were able to reduce significantly the AVM with one session of embolization, and he is due to come for a second session of embolization. So this was the post-embolization MRI, which shows there is a small residue. Obviously, the vein of Galen are a different set of disease, which may be choroidal or mural. You just get to the fistula. All you need to do is keep getting to the fistula and obliterating the fistula without putting too much glue into the vein. At the end, you can obliterate the vein as well. So this is a 2-year-old child with a mural fistula that was embolized and cure achieved. PL fistulas are high flow nature. Obviously, both when they are on the surface, both surgery and embolization work equally well. You have to reduce the flow in these fistula. These are very, very high flow situation. You have to reduce the flow. Reduction of the flow can be achieved by putting some coils on the venous side, or having a balloon on the arterial side, achieving hypotension, jugular compression. There are various techniques by which you obliterate these fistulas by selectively putting glue at the junction of the fistula with the artery. And these kind of deep-seated fistulas, obviously, they are not a surgical case. They can be treated effectively with endovascular embolization, obviously with the same technique of reducing the flow first and obliterating the fistula's location. Okay, adjunct to surgery. Yeah, this is a very, very important topic, which when effectively used, it's extremely useful. As Dr. Jabbar has shown in few of his cases, such deep-seated feeders in an AVM can be effectively embolized, and your surgery becomes fairly straightforward and simple. Dr. Goyal was saying that you need to have the technique of going into hemispheric, getting to these feeders and resecting this AVM. Exactly, that's what we do with endovascular embolization. We first get to these feeders, embolize partially, get the AVM relatively low flow, and then surgery becomes fairly straightforward. There's another case in the just posterior to the central sulcus. The patient has bled at about 4 weeks. We took her up for evaluation. This was the angiogram which had feeders from MCA and ACA as well. And here the MCA feeders are under your control. They are on the surface, and the venous drainage is medial. You need to go into hemispheric to achieve control of the ACA feeders. So the thought process was, I'm going to obliterate all the ACA feeders. The ACA feeders were quite robust. So what I achieved was, with Onyx, I was able to achieve with 2 pedicles a good control of the ACA feeders and obliterate the AVM from the medial side, and the residual AVM was surgically removed. You see now it's fairly a straightforward, simple game to play. This is another case of a medial occipital Avm, which is a deep-seated one. Here again, the patient presented with the bleed. The patient was relatively clinically intact, did not need urgent decompression. So I went ahead with embolization of the deep feeders. Here the plan was to preoperatively embolize the feeders and resect the AVM. As you can see here, when you do a preoperative embolization, you don't need to get into those nidus of the AVM. All you need to do is you need to go to each of these bigger pedicles, block, and once you block them, the AVM becomes relatively quiescent and surgery becomes fairly straightforward and simple. This is after embolization, before surgery, and we resected the AVM along with the evacuation of the hematoma. Pre-radiosurgical embolization. Yes, there is a role in medium and large size AVMs that has been well documented in the literature. The goal here is to reduce the size of the AVM. The smaller the target, the better the cure rate. And obviously we look for intranidal aneurysms, flow-related aneurysms. If it is a ruptured AVMs, obviously you need to get rid of those risk factors before you send them for radiosurgery. And obviously intranidal fistula is something, when you explore the AVM with super selective angiograms, if you see a fistula, those are the ones that you should target to obliterate. And obviously embolization is also used in certain situations where there is a residual AVM following radiosurgery. So does radiosurgery, does embolization prior to radiosurgery reduce its effect? There is a thought process that, when we use Onyx, the tantalum obscures the images and you may not have a good volume assessment for you to embolize. And there will be image distortion in the CT scan, and dose calibration would be difficult. Yes, in today's world, when you, as Dr. Jabbar just showed, if you use MRI with angiogram superimposition and you do a dose calculation, these kind of shortcomings can be overcome. This was one of those cases that I embolized like prior to radiosurgery. The volume reduction was achieved and the patient was sent. This was another patient where initial plan was to do embolization followed by surgical resection, but the patient did not want a surgery. So I embolized it with the goal that I may be able to achieve a cure, but there was a residue at the end of embolization and the patient was sent for radiosurgery, and following radiosurgery in about 3 years, she had complete obliteration. Target embolization is one controversial topic that we need to understand. The high risk situations in an angiogram has been well defined by senior authors early in 2000 and in the 1990s. And the role of target embolization has been defined first by Professor Valavanis and subsequently by many other authors. I'll just share one of my case where I've done a target embolization. This was a 67-year-old woman who was found to have an AVM, but she was managed conservatively. She came back with a bleed. As you can see, there is a bleed with intraventricular hemorrhage. This was a large AVM, and we were looking for the weak spots. She had one flow-related aneurysm in the MCA that was obliterated, but that was not the one that bled. Then we are looking for additional spots. We found this from the ACA collaterals. There was a weak spot, and we super selectively catheterized. You can see the intranidal aneurysm, and this aneurysm was super selectively catheterized, got very close to it, and we were able to embolize, reducing the risk of this AVM bleeding again. That is a target embolization. As you can see here, this was the location of the bleed, and here was our embolic agent. And we thought like a sniper, we got it right to the spot where it is bled. So there is a role for target embolization, but one should be aware that random partial embolization is a real no-no. It is not recommended, and it does not produce better clinical results. And it can, in fact, there are reports saying that it can increase the risk of hemorrhage on the long run. Optional role for embolization. There are some AVMs where if there is embolization, it's useful, but I can still deal without an embolization. This was a 43-year-old male who presented with headache and papilledema because of this venous obliteration. He had raised intracranial pressure, and he was found to have this AVM, and he had fetus from MCA as well as from PCA. The PCA fetus were fairly straightforward, and the AVM was on the surface. And in such situations, our 3D analysis of the AVM is extremely useful, and we are able to study, as Dr. Goyal was saying, studying these AVMs are extremely important, and then we go for direct resection even without embolization. But in an ideal situation, I would like to have embolization of the PCA fetus, which would make my life even more simpler. There are certain situations where there are no role for embolization. This is a 48-year-old male who presented with an intraparenchymal hemorrhage. Initial CTA was normal. His initial angiogram done at an outside institution was normal. And then he was treated conservatively. He recovered well. He went home. He didn't follow further. About 4 months later, he presented with another bleed. And this was the time he came to us, and when we did the angiogram, there was a diffuse nidus with a single draining vein, and there was no definite dedicated feeder. These are not the cases where we can even think about embolization. So I went for direct surgical resection with complete cure of that AVM. So when I look at AVM and the role of embolization, if it is a supratentorial surfacing AVM, mostly we go with microsurgical excision with embolization in certain situations. If the supratentorial deep, obviously embolization plays a pivotal role, and for the residual AVMs, we look at radiosurgery. Cerebellar hemispheric, obviously microsurgical excision and embolization forms a primary role. Cerebellar deep AVMs, embolization and radiosurgery plays equivalent role. Obviously in deep-seated AVMs like the brainstem, embolization is very important, and we can reduce the nidus. And if there is residue or there are feeders which we cannot catheterize, you can have two approaches. You wait for the AVM to mature over a period of time, and you can which will allow catheterization or go for direct radiosurgery. So in conclusion, yes, there is a role for embolization in brain AVMs, and the endovascular treatment has significantly progressed, and you can achieve cure only by embolization in select AVMs, not all the AVMs. You have to be very, very clear with that. And preoperative and pre-radiosurgical embolizations are very useful tool, and one has to use it judiciously to achieve cure. As Dr. Jabbar just said, like the enemy is the AVM, and you need to use all your tools to get rid of that. And partial embolization has no role, whereas target embolization has a role in large hemispheric untreatable AVMs. And yes, there are certain AVMs where you can treat without embolization. Thank you. Thank you so much for the opportunity.
Yeah. Thank you, Dr. Srinivasan. You have explained all different types of embolization, and then you and Professor Jawahar has basically stressed that multimodality is the way to go, and it's not microsurgery alone or radiosurgery alone or embolization alone. Um, um, Now we start off with the panel discussion. The panelists will present a case, and then in that case, they will ask the questions to each of the speakers also. The first case presentation will be by Professor Misra, and he will present a case and the queries what he has about all the speakers also.
Thank you, Manas and Clemens. Such a fine lecture. With every lecture, you think that this is the ideal treatment. So we started with a confusion, and I think at the end, we are still confused. So Dr. Goyal goes for the surgery, and Dr. Manmohan Singh goes for radiosurgery, Pascal goes for the multimodality, and then Dr. Srinivasan also dominantly the embolization. I am going to present two patients which are mirror image uploads of each other, and these are the posterior fossa AVM. The case one, 13-year female, presented on 21st January 20 with seizure, altered sensorium, fast deterioration, E2V3M5 was presentation, and then started posturing. Earlier, she has dysarthric voice, nystagmus at rest. The case 2 was a 35-year female, 1 week later, sudden onset headache, vomiting, altered sensorium. Then she also deteriorated fast, and we had no facility for DSA. So I take one by one these two cases. This first case one, when she deteriorated, we had put the patient on ventilator. We did EVD. There was some sign of improvement. You see that this is the outlet of fourth ventricle is blocked, and the hydrocephalus is coming up. And this was the CT angio, as you can see. It was a grade 3 AVM, and I don't have all the modalities with me. Surgery is rather the only modality with me. So I would like to ask the panelists, remaining panelists, that what is your advice in this? What will be your take on this case?
So you want me to answer this? What is the scene, Manas? What is the protocol?
The panelists, sir, then the speakers, sir. Dr. Daljit and Dr. Bayan.
Okay.
The speakers, sir.
Dr. Daljit.
Dr. Daljit. Dr. Daljit is there?
He ran away, it seems.
Or Dr. Bayan is there? Bayan.
Hello, yes. I think that this is quite a complex AVM, and I think that there is a role for super selective angiography to look for high-risk features. I agree with Dr. Srinivasan that partial embolization is often leads to more problems, but I think in this circumstance, targeted embolization of high-risk features, I suspect there may be an intranidal aneurysm or a high-flow fistula that is worthy of targeted embolization, followed up by allowing the patient to recover and considering delayed surgery at age 13 if the patient were older, considering delayed radiosurgery.
Manas, I'm there. Hello.
Yes, Dr. Daljit.
There's some problem with the network at my issue. I see there is a hematoma and there is a hydrocephalus which has started developing in this case. Ventricles, temporal horns are dilated, and frontal horn is already showing me evidence of dilatation. There's a large hematoma. So presence of this hematoma with this AVM, I would take up this for removal of hematoma along with the surgical excision. For me, it will not be a case for embolization.
Dr. Manmohan Singh.
Yeah, so I think this is not a very simple, straightforward case. So no doubt this has bled. If you look at the feeders, they are probably from maybe superior cerebellar and maybe from little bit of PCAs and other part of the even the basilar also. So I think the feeders are from everywhere. So to manage this case, maybe the conservative initially with that to alleviate that hydrocephalus and target embolization. And surgery is possible and it is doable, but it is likely to be challenging. So I will consider target embolization followed by the radiosurgery is likely to give a better result. So we can wait for at least 6 to 8 weeks, maybe 12 weeks till the hematoma resolves. And target embolization should be done at the earliest. Then wait for around 8 to 12 weeks and go ahead with the surgery or maybe with the radiosurgery. Radiosurgery is likely to be a better option here, because that the feeders are likely to be from multiple points and they may be away from your approach for the surgical corridor. So I think from CT angio, you cannot see exactly from where the feeders are coming. So DSA will be required to study this Avm well.
Dr. Atul Goyal?
Yeah, see this, one thing is this patient has just had quite a big bleed. My philosophy in this patient is certainly going to improve if you wait and observe for a period of time. This patient is going to improve. Her condition is not that bad. And AVM bleed and recovery is quite a norm rather than not a norm. So this patient, I will like to wait, number one. And second thing is to do a nice DSA to exactly show where are the feeders and where are what is bought and what is not bought. The other thing is the nidus is quite a compact nidus. And I will say this is a wonderful candidate for surgery, wonderful candidate. If the feeders are from PCA, SCA and all, we can come from this side and get feeders one by one. And I have a feeling, you see, I cannot have a feeling without DSA. I'm just having a feeling without having a real investigation. You see, you cannot operate such an AVM without an investigation. I do not know where is the, I will like to do MRI. I will like to know the relationship of this AVM with the brainstem. I will like to have a nice, proper DSA. And then, of course, my feeling is, you operate and you cure. The question is, and that question remains, whether you are able to operate or not. And I will say to do radiosurgery for this AVM may be the option if you are not able to operate, but that is a very, not such a great option. And to do, there are multiple feeders, PCA, ICA, ICA, and PICA, and all those feeders. This can be a beautiful case for surgery. You do partial embolization and all those things. I have a feeling this is a fantastic case for surgery. Although I don't have, cannot confirm and say because I don't have the investigation.
No, but sir, let's say patient has altered sensorium, score is 9. Okay, his plantars are extensor, hydrocephalus is settling down. Is it ethically correct to leave it to radiosurgery or as some treatment choice which would take time to show a response?
No,
Why not
it's a huge,
That's
it
exactly.
is a huge AVM. There is
That's
no question.
okay.
AVM, this is no case for radiosurgery, Manmohan.
Absolutely.
I'm surprised. How are you saying radiosurgery? And if
So-
you are doing embolization, 1 vessel, 2 vessel, you go on putting lava inside and the whole thing will be like a stone and the brainstem will be stony hard. You see, this is a case for surgery. If the DSA confirms my suspicion, this is quite a compact, beautiful nidus. This can be removed by fine microneurosurgery.
Dr. Pascal?
I would
Well,
like to.
in my opinion, this is a case that needs a decompression. The ventriculostomy is not going to take care of your mass effect in the posterior fossa. The ventriculostomy will take care of the hydrocephalus. This patient needed a ventriculostomy emergently. The next thing this patient needs is just to go right away because you see the mass effect on the brainstem. So this patient needs a decompression, knowing that you need to be ready with your micro instruments and your microscope in case it ruptures on you or you need to do the big AVM resection. You need to be ready to do it. Otherwise, what I would do is I would decompress, and then I will try to do super selective angiogram and see if I can embolize. But if, for example, this lady comes in the middle of the night I'd rather not go through the major surgery. That's a complex AVM of resecting it. I'll try to decompress first.
Should I, Pascal, just like to say one sentence? I am not saying you are correct or I am correct or you are wrong and I am correct. I'm not trying to say that. But what I am trying to say is I have completely abandoned this term decompression for such AVM, completely abandoned. No way I will do any kind of manipulation. Even I will not do, unless it is extremely patient is worsening or something like that, that is a different story. But these patients, once they bleed, they settle down and slowly and gradually they recover almost certainly. This word decompression for AVM surgery in particular, I have abandoned from my book completely. I am again saying, I am not saying you are wrong or I am right.
No, I understand. I understand. But in this case, I bet you if he shows us the lower cut, she has already herniation in the foramen magnum. This is mass effect in the posterior fossa. I wouldn't wait on that.
You are right, Dr. Pascal. Yes, it has a herniation. And the external ventricular drainage did only little bit favor, and we had to take it for the surgery. I think Dr. Srinivasan remains to for his comments. Dr. Srinivasan.
Yes, I too agree with Dr. Pascal with regards to the treatment option. I've faced this situation before. I mean, in this situation, I would go with an. I'm sorry.
You showed one case where you had done the decompression and then
correct. So we went ahead with external ventricular drain and decompression. The patient was having a repeated bradycardia just before we took her up for decompression, and she was crashing in front of her eyes. So the decompression and EVD, she stabilized. The second day she was extubated, and in about 5th day she was out of the ICU. And in 3 weeks we were able to analyze this AVM with MRI, with angiogram, and we were able to plan our treatment strategy. So that's what I would do here as well.
So I think that will enhancing the morbidity. You do 2 temporary procedures and then take one of the definitive procedures. Let me tell you what I did. This was the patient whose AVM was about 33.1 centimeter, and it was projecting into the CP angle. So it was a subpial AVM, and you see that the cranial nerves were open. I had no option but to go for the surgery. Once the patient had started breathing well after EVD, then we went for the surgery and we had removed it. It has a very stormy post-operative period. The post-operative, you can see that the MRIs, CT angiograms, they are not showing any evidence of AVM as far as, and the post-operative CT and post-operative MRI in the brain. And this patient who had a very stormy period, 6 months later, she is making to walk almost independently. She had a cranial nerve deficit of 7th and 8th nerve for some time, but they are in the recovery stage. So this is anybody wants to make some remark on this procedure what I did?
No, you did it
Beautiful
fantastic, my
result.
friend.
Very
Fantastic.
nice.
And I will compliment you. You see, the thing is, Dr. Mishra, if you think you can operate, if you think you can really operate, and if you have your confidence in yourself, and particularly, faith in yourself, and you have to see the angiogram, you have to see the feeders, and you have to see how far the feeders are from the brainstem and how much space you will get. Of course, you have done this without DSA, which is a little less than optimum. But removal is, even if you had DSA, this would have been the same thing. So I compliment, and I would have done the same thing.
This thing that DSA is not available at every place. At our place also it was not available. Then I go for the second case because there are the interest of time. This was a patient who again, almost a week later, again, this is bleeding which has blocked the 4th ventricle outlet. The patient started developing hydrocephalus. And this patient again deteriorated. We thought that nothing can be done. And once deteriorated, first they wanted to take another place. Once they saw that they cannot go because of deterioration, so we went ahead for the treatment at our place, and you can see that there is a AV malformation which is fed by mainly superior cerebral artery, and yes, Again, the same procedure, ventilator, EVDs, CT angio. Please opine yourself, Dr. Daljit. Dr. Daljit.
Unmute. Daljit, unmute.
Yes, sir, I'm there. Yeah. So I would definitely wait for this case for a definite DSA to get the entire picture of this. And maybe, I mean, I can't see it very clearly. This could be a case of selective embolizations. That is what I can make up right from the images which are there. There is no urgency to do any decompression. There is no urgency to put EVD also, because the score is not that bad. Score is around 12.
No,
And
that was the
maybe,
presentation score, Dr. Daljit. I think within 9 hours, this lady has gone to M12.
oh,
So I did,
so
if
deteriorated.
you can see that I did EVD, which showed some reversal. And
then the story is different, because she's already deteriorated. Score has gone to 3.
Both the things
Then,
that, both the cases had the same.
Right. In that case, I think I would definitely rely upon drainage of ventricle, whichever methods, to gain the time, see the response, and then take the call subsequently. That is my call in it.
Okay. Dr. Goel?
For me, you know what? For me, this is the easiest. I in my personal grading scale, this will land in the easy category, because you know it is in the posterior fossa, it is in the superior cerebellar artery territory, and it is in the cerebellum. What more AVM you want? You know, what more from the AVM you want? I think this is a beautiful case for surgery, but the thing is the patient should stabilize. You know, as I mentioned, I don't do any kind of ventricular drainage, decompression. These patients will eventually, you know, these patients eventually slowly, these are not hypertensive bleeds. These are not, you know, these are not those kind of bleeds. These are bleeds which they happen, and then the patients once bleed, and then slowly within few days the person improves. You have to, this is a surgical case. What selective and all those things, what selective? Now if somebody says Manmohan, don't Manmohan say that I will give radio surgery and all. If Manmohan you say, I will be disappointed by you, really. Manmohan, tell me what you will say. Do Manmohan. Don't say, oh, I will give radio surgery, my dear friend. You are a very caliber neurosurgeon. You are a well-known neurosurgeon of the country. And if you say, I will give radio surgery for this, I will be really disappointed, and I will all my whatever I have.
Intimidation. Intimidation is not allowed.
So the situation is that only the surgeon needs the radio surgery in this case, not the patient. So situation is that the patient has deteriorated in front of the surgeon's eyes, and he has gone down. And probably the reason for deterioration is multifocal, either the edema and the hematoma in the posterior fossa as well as hydrocephalus. This patient will require a decompression in the form of ventriculostomy, and this patient needs urgent surgery. So this is the superior vermian AVM, and maybe part of the superior part of the left, I think it is the left hemisphere, left cerebellar hemisphere is also involved. So these are very small nidus. You can go ahead, take out the hematoma, you take out the AVM, do the ventriculostomy, so decompress all the systems. And this patient is likely to do better in that way. And I think it will be a fool decision to give or think of radiosurgery in such cases.
Yes, Dr. Pascal.
So, looking at the CAT scan, in this case here, it's not as bad as the other one. I don't see a lot of mass effect. My question to you, did you say that she deteriorated even more clinically?
Yes.
Yeah, within 8 hours, she became M2.
Okay, if she deteriorated more, we need to go in. So in this case, more than the first case, I feel comfortable going without an angiogram. In this case, even in the middle of the night, that's much straightforward than the previous case. It's to the periphery. I would go in, resect the AVM and decompress at the same time. Can I treat this endovascularly? Well, if the patient didn't deteriorate clinically, it looks like this is has a couple of feeders from the SCA And I think we could have, I mean, of course, I need to see some super selective run, but we can have an angiographic obliteration for that AVM. But in this particular case, surgery and resection.
Clemens, you have not spoken so far.
Pascal, you are in politics also, or what? You are in surgery. You are good in surgery, I know. You are good in your bow ties, but you are also good in politics, huh?
Dr. Srinivasan? Dr. Srinivasan?
Yeah,
Yeah,
I agree with Pascal for the most part. I think this is one where the angiogram is really probably going to determine like which way you can go. I think, as it was pointed out, before, waiting on a patient like this and letting potentially the hemorrhage go away and having more room, maybe making more room for surgery. This is probably a great example of a true multimodality management. I'm curious to see what you actually did, but I think there's probably no wrong answer here.
Dr. Srinivasan?
Yeah, this AVM looks fairly straightforward. And if the patient was crashing, obviously we have no choice but to go decompress and go for the AVM in right away. I think this is fairly straightforward AVM, and this can be resected in the acute setting with or without an external ventricular drain with posterior fossa decompression, and the patient would usually recover. If the patient was clinically intact and remaining stable, I would just wait for it and then like do an angiogram, do my analysis, and look at the role for embolization. But if the patient was crashing, there is no role to do that, and we can go right away go for surgical resection.
Dr. Bray?
Yeah, I agree with the panel that this is a surgical lesion, although with the ability to bring someone to the angio suite expeditiously, I personally would do a quick angiogram and even potentially do a targeted embolization of some of the feeders, not going for distal penetration, but just knocking out what looks like 2 branches of those SCA feeders. That would, I think, rapidly expedite the surgery and really give me comfort taking the patient to the OR urgently.
Dr. Manas?
Look, in our setup, we will go for direct surgery without embolization.
So that is the same type of setup here. We went for surgery, and this is the post-operative MR and CT angiogram. I went ahead and removed the hematoma after EVD when patient showed little improvement. And these are the post-operative CT and MR angios. And you can see that this is a MRI done about a week ago. And this is I think, some hematoma part which is there in the center. And this is the post-operative CT. And the lady which was really very worse, very challenging in the post-operative has done much better as expected by all panelists. And this is the situation. She had a very bad period, underwent tracheostomy and all those things. But today you can see that this young lady and is ready for independent housemaking. So thank you very much. These were the 2 cases with me, which I wanted to share.
Yeah.
Any clarification or any comment?
Thank you, Professor Mishra, for having a very useful discussion on the 2 interesting cases. I request Professor Daljit to present a case for panel discussion. Dr. Daljit, please.
Yeah, I'm just coming out. There is some issue with my network. Let me share the screen first.
You are there on the screen, Daljit.
Yeah, yes, sir. I'm just coming up. Just give me a second. Okay. So while this was going on, I think we can come out with cases which one could always debate which treatment modality is superior over to another. So I changed my mind of case to be presented. And I think there'll be no controversies among the panelists about the way of treatment, particularly Dr. Atul Goyal. I mean, this case is for Atul Goyal. So this is a scan of a patient in January 2018, 2-year-old case, 50-year-old female, road traffic accident. She had a GCS of 8. Pupils were normal size reactant. She was hemodynamically unstable on ventilator. So she went decompressive craniotomy elsewhere, January
Can you put at a
2018.
view?
Is it
You
not?
click the
So,
view.
yeah, just came in, sir. Is it not there? Not coming? Can you not see the? Yeah, okay. Is that okay?
Yeah.
Yeah. So she underwent a decompressive craniotomy for this scan elsewhere. Improved to some extent. GCS was 14 following surgery. She continued to have some agitatory behaviors. 6 months after the head injury, she started complaining of headache, some behavior problems, and proptosis initially on the right eye, subsequently onto the left eye, and the loss of vision in both the eyes. She came to us with this scan. Immigration of ventricle, large size defect, good size of decompressive craniotomy. Problems now was proptosis in both the eyes, and this was the condition. So the diagnosis is quite obvious, Dr. Atul Goyal. I don't think there is a role of surgery or a this. This was her TSA. We have large veins filling up bilaterally, cortico-cavernous fistula, right side, it was filling both the cavernous fistula. So I don't think there is definitely certain conditions when surgery is out, there is a role of endovascular treatment, dogmatically straightforward, simple and all. And we thought, okay, fine, this is the case for embolization, and we took for the embolization. This is my coil cast on the right image. This was the left one coil, and the patient was immediately post-operative. See, the tube is still there. On table, both the eyes proptosis improved significantly. So I think rather than being very selective that endovascular treatment is not there in all kind of arteriovenous malformation, there are certain definite superiority in certain conditions where it has a place. So I continue with the problem with that is, again, for the rest of the people who are doing endovascular treatment. So it is a costly affair. One can now use flow diverter. Balloons have been used by us also in the past. So we started measuring intrafistula pressure measurement in the treatment of CCF. Okay, and this is what we do. Now, if you can see this image, the red is blood pressure of the patient. We take microcatheter into the fistula, connect with the arterial line, and start recording the intrafistulous pressure in these patients. To begin with, the pressure is generally as close to the systolic blood pressure. So, but when you start putting up the coil, we recorded the fistula pressure start decreasing. Say blood pressure is around 129/64, and fistula pressure has significantly fallen from 110 to around 67. And that's where we started doing our studies. Another case, fistula pressure fallen to 70. And in those situations, we wait for the fistula to close spontaneously rather than putting more coils into this. Like for example, over here, you see the coils have been put into the fistula is still filling, but my pressure has fallen significantly from 110 to 60/64, and we wait. And after waiting for about 20 minutes to 30 minutes, take another shoot, the entire fistula disappear. Another case I would show. Sorry. Yeah, this is the case. See again, the catheter is showing, this catheter has eventually come out while we were doing the procedure. The fistula is still filling. We waited for about 20-30 minutes. The pressure had declined significantly from the original pressure recording, and nothing else is to be done. Ophthalmic artery starts filling up, entire fistula disappears, and it's a complete cure. So I think case like this, they're more satisfying. You get to see the result instantaneously. There are cases of vascular malformation, particularly the fistula. Recording of the fistula can be quite a useful thing when we can treat these conditions without radiosurgery, without surgery as such or without any other thing. There is a definite superiority of endovascular treatment in such conditions. Thank you so much. Manas.
Yeah. I think there's no controversy, but I'll ask Professor Pascal to give a comment because he gave.
So I want to say one comment. I know Professor Goel is more than capable of treating this surgically, but he knows that it's not the right thing to do. There's a difference between if you're able technically to do it or if it's the right thing to do it. I see he's nodding, so at least we agree on something.
Yeah, I just want to add this was such an elegant and objective way to guide your treatment. And I think it's highly underutilized in the endovascular realm. For my vein of Galen treatments, I would often leave a pressure transducer. I would use a Volcano Verata pressure guide wire, the same wire, the transducer wire the cardiologists use, and I would put it in the vein of Galen as I sequentially either coiled the vein of Galen transvenously or embolized arterial feeders transarterially. And once again, I think it's just a lovely way to objectively gauge the progressive occlusion of any type of AV fistula that is underutilized. So kudos to you.
Thank you.
Brian, I have a question for you. So in CC fistula, are you using do you undertreat and wait, or you just go for an angiographic cure, keep on either coiling or keep on injecting liquid embolic until you don't have any fistula anymore?
There are certain circumstances, particularly for complex high flow fistulas, where I think the goal is always to cure it in one fell swoop. But when you start thinking about the timing of the procedure, the radiation dose, the contrast dose, I will use a pressure wire until I see about a 50% reduction in pressure, because I never stop until I see an objective reduction in pressure. Once again, the goal is always to cure it, but sometimes in a single session, that I think that probably puts the patient at greater risk than necessary.
Yeah,
and you add cost to the treatment also. You know, you're putting more and more of devices inside the fistula. What if nature also is taking care by reducing pressure and thrombus is forming? It just takes up I mean, a natural way of treatment by reducing the flow, by gauging the pressure itself. So you save on a lot of money by putting a lot of coils in these places.
Yeah, I think also
curious.
to go with what Brian was just saying, like sometimes if you have more than one feeder and you have to decide if you want to go to that next larger feeder or stop at that point, looking at the venous pressure may be helpful, right? Because it like really shows you like if you've done enough for today sometimes.
Yeah, but not CC fistulas. You all agree, right?
Dr. Srinivasan, you comment anything?
If you're going venous from the venous side to a CT fistula, you're gonna go ahead and treat it. I agree this checking pressure in complex arteriovenous fistulas or dural arteriovenous fistulas, but not CC fistulas, in my opinion.
Yeah, for CC fistulas, I think if you're going transvenous, I think practically you need to occlude the ophthalmic outlet so that you bring the patient out of the symptoms, and the residual fistula, if it's draining forwards into the inferior petrosal sinus, then you're still okay, leaving a little bit behind. But leaving the anterior channel open, I wouldn't come out with the CC fistula. I'll go all out to cure it angiographically at least.
No, let me clarify. All our cases are transarterial route. We have not taken transvenous. Okay, fine. So the catheter has gone from the arterial side close to the fistula.
Yeah, because it's a type A. You need to get to the cavernous sinus. And in this case, you went transarterial. But it's the same. You're in the cavernous sinus. Yeah,
exactly.
And the practical problem on the transvenous route is that once you're out, like once you pull your axis out, you may not be able to get to that same area back ever again, right? So that's where you shouldn't stop, right? Because you're there.
And you should strategize in a way you go to the farthest distance and you come backwards coiling it. And you should first go to the superior or inferior ophthalmic vein, and from there come back and seal it off.
Yeah, that's a normal way of doing.
Okay, you know what? Should I make a comment? You see, one thing is, you please don't get me wrong. In AVM surgery, there is no place for pride and ego and hyperness. I can do. There is no place. Believe me, and I completely believe. You have to put your head down when you are going to treat AVM, and you have to be very, very down to, you should walk with a very wide gait. You cannot be hyper and create a mockery of yourself. You go, I will do, and I am super, and I am, with that kind of pride and proud in your egoistic attitude, and you make a mockery of it during the surgery. You cannot do that, period. If you do that, you will be thrashed from, not only from the theater, your assistant will laugh at you. When you turn on that side, you will see the nurse laughing and the anesthetist laughing, what an idiot this fellow is. You cannot do that. You cannot have hyper ego and pride. You have to be on the ground, and you have to be very religiously. Sometimes you have to see the angiogram for 24 hours at a stretch. You cannot say, I have seen the angiogram, yeah, I am a hero and I can do it. You cannot have that kind of situation. That is number one. And you must agree to what I am saying. Those who are doing surgery for AVMs should agree to this, period. As far as, Srinivasan also, you don't get me wrong. I'm a very big fan of endovascular treatment. And Daljit, for you will not know, you were not born at that time, carotico-cavernous fistula, we were treating by surgery at one point of time. Fabian Isamat, during those days, he had introduced treatment for, getting the meningohypophyseal trunk and putting glue and putting muscle and putting all those things in the cavernous sinus. I was doing myself. But for last 35 years or 30 years, we have not done any carotico-cavernous fistula by surgery. And I have no confusion that there is no role for surgery in this kind of carotico. There is no confusion in my mind. There is no confusion in my mind that lot of basilar artery, lot of posterior circulation, lot of giant. I was doing bypasses all the time. Now all my bypasses have been taken away, for aneurysms in the supracrinoid, to cavernous aneurysms. They are all gone from surgical domain. So don't misunderstand me that I am, hyper and I want to do this and that, and I don't like embolization and I don't like endovascular. But bottom line is, our discussion today is on AVM. And AVM, even Jack Moret, who was a very big fan of AVM embolization at one time, later became quite anti-AVM embolization. And now he has again become pro-AVM embolization because he is now doing venous route and he's demonstrating and he's successfully. But still, at least till 5 years ago, he was confused in his mind. Ask Jack Moret, you know Jack Moret, and he was himself saying that I am 5 years ago that I am not completely convinced about AVM embolization. And I am saying my experience. I am not saying what others think and others do not think. I am saying that I do not like pre-operative embolization for AVMs where I am going to operate. But I am not saying if something is already embolized, I will not touch and all those things, but it does not really make my life easy. And now my experience for AVM surgery is beyond nearing 600 AVMs. So I'm not talking from a small experience or little bit here. I was shown trophies and do not show bad things and all. From my experience, I'm saying the role for embolization is still evolving. I am sure embolization with experts like on the panel, they are already very convinced, but many of the AVMs that Srinivasan you showed were quite straightforward for surgical cases. And I know you are a good surgeon. Many of these you operate and finish them off. Why you want to put unnecessary tubes and all those things and lava inside unnecessarily? Wherever you can operate, you operate. That is the best for the patient.
Yeah. Professor Goel, thank you. We have one more case presentation. Is Dr.
I want to add one more thing.
Yeah.
Professor Goel has such passion. He says everything with passion. It's hard for us not to agree with him. Even if he says embolization is bad, I have to agree with him. He says it with passion.
No, but I think he raised an excellent point, which is maybe worth restating, that at the end of the day, the treatment team that is caring for one given patient is local, right? So whatever works for your team, especially if you're not providing all perspectives or all sorts of, all modalities by yourself, you got to work with your team, right? So if he in his environment says, I don't like preoperative embolization because it doesn't help me, then, you know, that is an important nuance, right? That may be different for someone else, right? Because they may actually like the preoperative embolization, but it really is, you know, whatever the results that come out of that, you know, count.
Yeah, but Clemens, my concern is, in lieu of a case, I'll actually just pose this to the group. My concern is when you don't have someone like Dr. Goel on your team, someone who is becoming a dinosaur, if you will, because there are so few people who have his surgical experience or gravitas. How are we going to address these issues down the road? Because in 10 years, we won't be able to have many discussions like this where someone like Dr. Goel can come in and give us such clarity on surgical opinions. Because quite frankly, in order of comfort, as someone who does all three things, I am probably most comfortable with endovascular embolization, then radiosurgery, then open surgery for AVMs, particularly ruptured AVMs. And I think we're going to see that become all too common, certainly in the US, certainly in Europe. I can't comment on India. And for Dr. Goel and the team, how are we going to address this moving forward, training individuals with a disease process that's already rare and becoming increasingly so with the advent of endovascular cure and radiosurgery?
No, you are absolutely correct. And I am absolutely convinced that there are not even, if you count on your fingers, there are not even 20 or 25 people in the world today who can say with confidence that I can do AVM surgery, period, to say like that. Do you have 25 people in the world? So if you do not have so many people in the world, so that is why my first sentence was in my lecture that endovascular treatment will survive, and not only survive, but thrive. Radiation today may be at a little bit lower edge, but it will, even endovascular treatment may not survive, radiation will survive, because there are not many people who can do it. That is the issue. You know what? But many of these AVMs, with my current feeling, is that we should be advocating surgery because they are easily and beautifully amenable to surgery. We should not neglect this field because this is a fantastic way of treating. And even you will say that you will not like, if suppose I will ask you one question. If you have confidence in me, and I have confidence that I will remove this AVM, don't worry about it, my dear friend. Will you like somebody to put some foreign material and onyx and all those things and load your head with all these things unnecessarily? When somebody with confidence, and you should have confidence in me. That is the bottom line of this problem.
Yeah, I think, Brian, you raised obviously the crucial question, and I think the usual answer of this is always that we're going to talk about regionalization, right, or centralization of some of these more complex cases. But I think the devil is really in the details, and I don't think we have a great answer for this, to be fair, right? Because you know, nobody wants to give up cases, nobody wants to step back and say like, if this is really something we need to send to, you know, Professor Goel in India, right? Because he's the only one who can do it. You know, I think that happens sometimes, but it's probably not often enough in the interest of the patients.
Yeah, thank you, Dr. Clemens, for the comment. But the future is probably a multimodality where when all the centers have all the modalities with experienced people doing embolization, surgery, and radiosurgery for the benefit of patient. Unfortunately, in country like India, it may take very long time for all centers to have experienced people and infrastructure for all three modalities available. At present in India, there are few centers which has all the three modalities available, unlike US many centers. So we have a long way to go to have multimodality management. Probably at present, Dr. Srinivas in his center, embolization is good, but many centers like us, we have to follow Professor Goel because, and Professor Misra has presented, where he doesn't have DSA also, so he has to do with a CT angio. So for many centers, microsurgery is the first option, as Professor Goel has promoted, and it is useful. So maybe 20-25 years down the lane, it will become like US, where multimodality will be the way to go. With this, I'd like to close the session.
Can I ask two small questions?
Yes.
My question to all panelists, one thing that in the classification of AVM, why the GCS or the condition of the patient has not been given any
Importance.
importance in choosing the modality of the treatment, because this does affect this thing. We cannot wait in some patients. We have to go in. So that is one question. And second question is regarding spinal AVM. What is the call for the spinal AVM by those who are expert in them? Anybody who can answer.
I think the second question we'll answer in another webinar.
Yeah, the spinal
Yeah,
AVMs are a different
yeah.
ball game, and
Yeah.
obviously they can be treated quite effectively. And I think trying to achieve a cure on spinal AVM increases the risk of deficits more commonly. I think with the intraoperative monitoring being available, a significant amount of embolization and long-term stability of these AVMs can be achieved in spinal AVMs with even near total embolizations. That's pretty good. For surfacing lesions, posterior ones, I think surgery is better. But for other AVMs, I think we should, I'm talking about the intraparenchymal AVMs, not the dural AV fistulas. I think embolization to achieve near total occlusion and partial occlusion holds good.
Now, should I answer Mishra's first question? Now, question number thing is, he's saying that the GCS should be included in the classification. My answer is it should not be included. Now, I will say why it should not be included. Suppose there is a very nasty kind of aneurysm. You cannot say that the GCS is poor, let me just operate, because patient is already quite low in the sensorium. There is no harm in being operated. It does not work like this. What works is whether I will be able to remove it. No matter how is the condition of the patient, whether I will not have a situation where the bleeding overtakes me. So that becomes the bottom line. So when you see the AVM, you have to see how is the AVM being fed, how is the nidus, how is the flow in the AVM, where is the AVM located, whether I will be able to dissect or not, whether I will be able to completely come out with the AVM and with the patient. Those things matter more. It will not be a situation that it is such a bad AVM, but because the patient is lying unconscious, I just go ahead and make a mockery of it during the operation. You understand what I'm saying, Dr. Mishra?
Yeah,
So
but
it is very, when the
to...
patient is little bit down, you can take a little bit extra risk. Maybe little bit, you can say, okay, let me take little bit extra risk, but not beyond a point.
Should the condition of the patient, like in any neurosurgical cranial surgery, we bother about the result, and result is based on the neurological status. In AVM, why it doesn't stand like that?
No, it stands. It stands. You know what happens is, suppose that, just listen to me. What I'm saying is, suppose the AVM is in the motor area. Suppose the AVM is in the motor area. As I was mentioning, the patient comes with hemiplegia and with a hematoma. Okay.
Yeah.
Now, my attitude towards this was, if I wait for a period of 2 months or 3 months, this hemiplegia will certainly recover. This was my attitude. So I used to wait for 3 months. So the danger was, if I am operating, I can create hemiplegia in a motor strip AVM. So nowadays what I am doing is I operate in an acute stage, because it gives me certain kind of confidence levels as regard the patient will not disturb me if the hemiplegia does not recover. But that is not a good attitude.
I will be able to explain you in Siddhivinayak temple.
So can I come over here for a second? So Spetzler-Martin grading or any other grading which is talking about, they are telling independent predictive factors in the outcome depending upon the grade, irrespective of what may be the clinical status. Okay. So grade 1, 2, they say, of course, you remove it, results are likely to be pretty good. Grade 3, 4, you remove it, morbidity and mortality is higher. Now they're talking of irrespective of clinical GCS grading. Now one can add on to the further outcome depending upon the neurological status, as you yourself said, depending upon the neurological condition that would remain. So that has been not included, only to say irrespective of whether the patient has bled or not or neurological status, what will happen in those grade 4 grades outcome of these patients.
So you should try my grading scale. If you are operating, Mishra,
that,
We have come to the same point.
that grading scale is applicable for all neurosurgical operations, sir.
no,
When
that is a
I
personal
will
grading
meet
scale.
Dr.
Don't make a,
Goel,
it is a wonderful grading scale when I see myself. Your grading scale may be different,
No,
but
no,
that
so that's the thing,
personalized
yeah.
grading scale is a good scale.
No,
For all cases, you are right.
I'm saying for all cases, it's not for AVM alone.
Yeah, yeah.
I think I will convince Dr. Atul Goel when I come to sit the Vinayak temple.
So we have passed 20 minutes our time because people have to go to work in US.
Okay.
So, Dr. Clemens and Dr.
Thank you,
Priya,
Dr.
Dr.
Manas.
Pascal. He has already left because he had to go for surgery. For spending the time in the webinar, I'd like to thank Professor Goel, Professor Mishra, Professor Daljit, Professor Srinivasan, Professor Manmohan Singh to participate in the webinar and give the lectures and teach all the people here. Please keep free for the next webinar. It will be on vascular tumors. It's on November 11th. There is a second Wednesday of the month. So with this, goodbye and good night. And thank you. Bye.
Yeah, thank you.
Thank you all panelist participants.
Thank you.
Thank you.
So much.
Thank you.
Thank
Bye-bye.
you.
Bye-bye.
Thank you. Bye-bye.
Thank you, Dr. Goel. Okay,
Thank
bye.
you. Bye-bye. Thank you, Clemens. Bye.
Thank you.
Thank you,
Bye,
Dr.
Manmohan.
Thank you.
Hello.
Yes, sir.
Jagrup is there or left?
No, sir. I think he had just now he had left.
Okay. Thank you, Mr. Virender. And
no, thank you very much, sir. It's more a wonderful experience for the learning.
Thank you for the support. And next
Always,
time.
sir. Yeah, always, sir. Yeah. Pleasure, sir.
Thank you.
Good day, sir.